Welcome to this week's episode of the Asthma Spotlight podcast. And today, I wanted to focus particularly on asthma attacks, which are both dangerous and very frightening, especially for children and parents of children with asthma. But sadly, they're not taken very seriously by many people with asthma, and they're also not taken very seriously by many healthcare professionals. And so today, it's my great pleasure to be joined by two people who are specialists in their own fields in asthma in Northern Ireland. And I invited them because I read a fantastic paper that they'd both been involved in, some fantastic work that they did, which really helped to address the issue related to asthma attacks. And one of the big issues was really follow-up to try and prevent another one. So I'm joined by Leslie Kennedy and Mike Shields, and so welcome to both of you.
Thank you.
Okay, yep.
So would you like to introduce yourselves? So let's start with Leslie.
Hi, my name is Leslie Kennedy. I'm a paediatric or children's asthma and allergy nurse specialist based in the Northern Trust in Northern Ireland. Previous to this, I worked in our tertiary centre in Belfast, but I've had an interest in asthma for many, many years. I also sit as chair of the National Paediatric Respiratory and Allergy Nurses Network Group. So asthma is really something that I'm very passionate about.
Thanks, Leslie. And Mike?
Hi, I'm Mike Shields. I'm a recently retired consultant paediatrician in respiratory medicine at the Children's Hospital in Belfast. And also I was Professor of Child Health at Queen's University Belfast. And I, over the last 30 or 40 years, set up children's respiratory services in Northern Ireland with a special emphasis on asthma and difficult asthma.
Thanks. So welcome, both of you. So could you start by describing for our listeners what the situation is regarding asthma in Northern Ireland? And again, so Leslie, if you'd like to start on that.
Well, I think in Northern Ireland, it's like most of the UK. Since COVID, we've seen a massive increase in the number of patients being referred through the ED departments and the acute setting of the ward, who then eventually come through to myself in clinic. I think numbers are definitely rising. I think people are becoming a little bit more aware of the issues if their child is wheezing, but I'm not 100% sure that our services are meeting that need. And I think it's the same throughout the whole of the UK, mainly because of financial restrictions and just that there's no capacity or people who have been trained specially to deal with that situation. I'm not sure, Mike, if you would agree with that or...
Yeah, over many years, I've noticed sort of what's good in Northern Ireland and what's bad. And certainly Asthma UK, the charity, does an annual survey. And Northern Ireland has always come up on the top of the four nations in terms of the number of people that report that they have the basics of asthma care given to them. However, the sad thing about that is, although we may be best, it's still less than 50% of people with asthma actually are getting a program of asthma education and training. So most people, in fact, more than 50% children and adults in Northern Ireland are not being given the basics of asthma care in order to try and prevent a future acute asthma attack.
And so is the situation there the same as the rest of the UK, where asthma care is delegated mainly to those in primary care, and even then to people without adequate training in asthma?
Yes, I think definitely primary care. The expectation is that primary care will manage a lot of the asthmatics within the community. It's the same as the rest of the UK, and again, the training is not foremost. And practice nurses do the best they can, but they can't be experts in everything. And I think a lot of them are very adult orientated. So when it comes to children's asthma, they're unsure about what way to proceed with different inhalers. Some of them are very good and have done training and know where to go to ask for advice. But I think it's similar to the rest of the UK. And as Mike has said, asthma Lung UK published statistics in 2021, and every 20 minutes a child's being admitted in the UK to a hospital with an acute asthma attack, which obviously we would love to see reduced, but that all comes with preventative treatment.
And Mike, what about hospital provision of asthma care? I'm aware that there's certainly a shortage of specialist respiratory pediatricians or pediatricians with a special interest or special expertise in asthma. And so how have you dealt with that in your work, in particular in dealing with pediatric generalists who may not be as aware of what's needed in people with asthma?
Yep, I think what we have done over the many years, we've audited within hospital the acute care, the acute asthma care. So how well are children who are admitted managed? And overall, we do very well. And that's all the district general hospitals and the children's hospital for the acute care. But where the big problem has been is the discharge. They've been sent home because children are now sent home very quickly. So you come in, a child very breathless and wheezing, but as soon as they're out of oxygen, they're virtually sent home. And what we were very poor at was actually putting in place a program to try and prevent a future admission. And the other thing that we found was for every 10 children, for every one child that was admitted to hospital, 10 children were appearing recurrently at the ED department for crisis management. So they weren't severe enough to need admitted, but they had an asthma attack that required them to come to the ED department. They were treated and then sent home. And largely they were being sent home to be seen by the GP. But we found that very few of them actually ever went to the GP, even though they were told to. Most of them never actually saw the GP. So we felt that that was a big area, and I suspect it's the same throughout the whole of the UK, that interface between the hospital, particularly the ED department, and general practice.
Yeah, that brings us very nicely to the work that you did, because as you say, there's an expectation that the GP or the nurse in general practice is going to take over the care of the patient when they've been discharged home. And sadly, like you say, many people don't attend. And it comes back to the point that I made earlier, that asthma attacks are not taken seriously enough, both by parents or by doctors. Can you talk a bit about what you did? I mean, this was the Children's Safe Asthma Discharge pathway, which you developed. How did you set it up? And then what were you aiming to achieve?
Well, I'll talk about how we set it up, and Leslie can talk about how it was delivered, as she was largely the person delivering it. But we'd become, over the years, very concerned about the number of children attending the ED department, but not being admitted, but not having any been put on any asthma preventers, i.e. trying to prevent a future attack. And we were very aware that an acute attack of asthma is actually a very good predictor of a future attack. So it was a real window of opportunity to try and get that as an entry point to a program of asthma care. So I, along with a colleague from a district general hospital, approached the Department of Health. They were going to try and do, in the particular year, we went 2 care pathways, and ours was one that was picked. And so we had a series of meetings with people with asthma, asthma nurses, the ED consultants from Children's Hospital, primary care. We all met together and decided that how we were going to design this care pathway. And one of the striking things that I can remember really coming from the patients and parents, there were several there, they wanted it done properly and with no concessions to cutting corners and doing it not so well. And so what we set up was we were going to see children. We planned to see them between 1 and 2 weeks following discharge from the ED department. And we had to firstly have a safe mechanism so that they wouldn't pitch back within a day or two back to the ED department. So we created an immediate safe asthma discharge pro forma, which was given to the parents, to the doctors, and was also it was stored, and the asthma nurse would then come and collect it.
This was information which you shared with the general practitioners.
Yes, it was shared with the general practitioner, the patient. It was put in the patient's notes from the ED, and it also was put into a box. And Leslie would have gone round each day and collected all the ones that were there. And the aim of that, we explained that they needed to take the patient needed to take their blue bronchodilator reliever until they'd stopped feeling tight and wheezy completely, and also they had to finish their course of oral prednisolone. It was typically a 3-day course, and during our study, we actually changed to a single dose of, instead of prednisolone, it changed to dexamethasone. So it was a single dose that was actually given in the ED department that then made things easier. And then Leslie the asthma nurse would collect the patients, and we had a system whereby we made sure that the patient knew they were going to be called to come to a clinic. So it wasn't just out of the blue and unexpected. They knew that was going to happen within 1 to 2 weeks. And an appointment was then arranged. And obviously, if there was a few didn't come, Leslie would have phoned them up and got them to come. And so that was the getting them people entering into the care pathway. So it was following an acute attack when there was obviously some degree of anxiety. We wanted it to be at least 1 week later, so that most children would be over their acute attack, but not more than 2 to 3 weeks, because our previous audit had shown if you wait 4+ weeks, a lot of patients then don't attend, because obviously the worry and anxiety of that acute attack has now faded. So that was our timing of it. And then the second point was what was the nurse going to do in an asthma program of care? And the first 2 things were it was going to be based on the personalized asthma action plan, and also making sure that children were trained, what I'm going to call trained to mastery of their inhaler technique. And that did not mean just simply being shown how to use their inhaler. It was understanding why they took each step. They could teach that back to the nurse and also demonstrate it, that they could do it back before they could leave the clinic. We were also aware that they needed to do that with the personalized action plan. So they needed to be able to describe when they're well, i.e. in the green zone, what do you take when you're well? You take your preventer regularly. Then what would you do at the amber zone, at the first sign that things are starting to deteriorate, maybe with a head cold? What do you do to try and see if you could stop it? And thirdly, and most importantly, the red zone, what to do if you're in the middle of an acute attack of asthma and are maybe becoming very breathless and can't speak. How can you help somebody, or what do you actually do? So we made sure that they could using the teach back, that they could describe each of those zones back to the asthma nurse. And the third thing we wanted was that there were 3 visits in quick succession, so 3 visits within sort of 8 to 9 weeks. And the reason being for that is there's quite a lot of evidence that good inhaler technique and understanding decays over a period of 3 to 4 weeks. And that you need to reinforce it fairly rapidly. So we decided that we would use we would have 3 visits, and then at the end of that, the asthma nurse would decide if the person with asthma was well controlled, they could go back to primary care. And if they weren't well controlled, more visits, or if they needed more education or more training, further visits were put in place. So Leslie can actually probably describe to you the actual nuts and bolts because she was doing it.
Before I ask Leslie to explain what happens next, so what you've really demonstrated is a fantastic approach which actually applies evidence that we're aware that works, and also a very thoughtful approach to try and make sure that the needs of the patients, the needs of the children and the families are addressed. Because from what you're saying, before a child left hospital after having an acute asthma attack, they were able to use their inhaler. Somebody made sure they're able to use their inhaler, and they also understood their self-management plan, so they knew when to call for help if things went wrong. And these are two very, very important things that don't often get addressed. And then thirdly, you made sure that before discharging these children to primary care, that they'd seen a nurse specialist who made sure that they were well controlled. Leslie, if you can carry on and tell us how you managed to actually contact these patients and get them to attend, because that's always been a challenge for many people.
So the first thing we had to do, obviously, was, I suppose it was one of the issues, was getting a room that we could use for our clinics. So we did that. And then we had to be guaranteed time. So we got 40 to 45 minutes for a new patient and 30 minutes for every review patient, which gives us the time to do everything that we need to do and take an adequate history. The patients who came in as inpatients would have been seen on the ward, and at that stage we would have gone through history, etc., with those patients. So they were leaving the ward having had really an initial interview with an asthma nurse specialist. Again, it was putting the essentials in place, which was inhaler technique, talking about adherence to their preventative treatment, talking about daily management and what to do, especially what to do if their symptoms did get worse. Because we couldn't be within the ED department, there was a performa developed whereby it was all written down, and it was up to myself to go down and train the staff in the ED department to ensure that they knew what to do. And the capture there were the ED nurses, because they were the constant within an ED department, to be able to point locum doctors and new staff, etc., to the safe asthma discharge pathway. So they would have gone through, the doctors would have gone through the performa, and the nurses would have checked inhaler technique, because that was something they were trained to be able to do as well. So I suppose it is a team effort. Then those patients obviously knew that they were going to be recalled, because the ED staff would have said, this is now, you're going to get an appointment sent out. We are seeing them within 2 weeks. So we had a secretary who then sent out appointments to the patient with a number that they could contact if they had to cancel or rebook. And then they came along to clinic. And as Mike has already said, if they didn't come, then we contacted them to see why, and explained that it was important for them to come to get these things all sorted out with their child. I think because a lot of people do, in spite of the fact that it is a breathing condition and that being able to breathe is essential for life, I think a lot of people underestimate asthma and don't realise that it can really be very severe and can be life-threatening if it's not managed properly and if preventative treatment is not taken. So a lot of those patients came back. And when we audited the safe asthma discharge pathway, we looked at 81 patients, the first 81 patients who'd come through, and all of those patients attended at least once to the clinic to have those essentials put into place. During our clinic, we would have carried out spirometry if necessary. We would have carried out, which would look at how their lungs were working, basically. And we looked at what we call fractional exhaled nitric oxide, or FeNO, and that was looking at degrees of inflammation. But the main crux of the whole thing was history, triggers, and talking about that again and again, and talking about adherence to treatment, inhaler technique. And as Mike has said, we embed everything throughout the consultation. So it's not a case of just showing the patient what they're meant to do. The patient the patient and parents would have talked back, and we would have checked that they really understood the personalised asthma action plan, which was written out with them there in clinic, and that they understood their inhaler technique, and that they understood when they should take the preventative treatment. And so many times parents have said to me, nobody has ever told me what I was meant to do, and nobody ever showed me the difference between my inhalers. So of course they were using the relief inhaler because they felt that it worked, or their child felt it worked, because they didn't realize that the preventative inhaler was something that was important, and it didn't give them any particular feeling when they took it. So again, we felt that that was important in clinic. Adherence to treatment as well, and telling them how to know when their inhaler was empty or how to work out when their inhalers were empty was another big thing, and how to get repeat prescriptions.
What a lot of healthcare professionals say is that they don't really have time to do all of this. And how were you able to secure that time? Because these people were all being seen, these children were all being seen by specialist respiratory nurses. Was that all you, or did you have other people who helped?
There were other nurses on the team, so we had the equivalent of two whole-time specialist nurses working, and over the space of a week, we would have had about 6 clinics, which were nurse-led between us all. We also would have done clinics alongside the consultants, whereby we again would have been checking and helping patients demonstrate correct inhaler technique. Those were both based within the hospital and within the community, in the community centres. So it was busy, but it's doable. But that was our job, as well as a little bit of allergy alongside that.
Okay, and so what's also fascinating is that all of these children came back at least once. And what was the secret? And so really for parents and for healthcare professionals that listen to the podcast, what would you say was the most important thing that ensured that people did come back? I mean, did you scare the hell out of the parents, or what did you do?
No, I think any parent who has had a child who has experienced an asthma attack or an exacerbation of their symptoms, it is very frightening. And I always would say to parents, your child will do their best until they can't. And that is really frightening. So it's about education. So when we would have phoned them up, we'd have said, look, your child has already been in acutely, and really this would benefit them to try and prevent them having to be back in hospital again, which obviously causes disruption to families. It just causes disruption to child education, sleep. And there's a fear. And I think probably because of media now, and because parents are more reading on internet, they see that there are those dangers for children who have asthma attacks, and that in some cases they're seeking that help. But for most of the parents, whenever we would have initially contacted them, if they hadn't come, they were quite happy to come again, because they knew that that was a way of preventing any further admissions, because that's disruption to a child, and to try and prevent sleepless nights. Because I think parents, especially again, I feel since COVID, children seem to be having a more severe response to viruses that are throughout the winter months, and parents want to do all they can to try and prevent that disruption to a child's life and that danger to a child who's not able to breathe. So that was how I suppose they just came back, maybe just because we were very nice to them on the phone. But there were no incentives. They just had to come back and bring their child with them.
We did make it clear, though, on the wee pro forma that the patient got from the ED, that I think at the top of it, it said asthma can kill.
Asthma can kill, yeah.
And we made them quite aware of that. And the reason we were bringing them back to this clinic, this special clinic, was to try and reduce their chances of having another asthma attack in the future.
Did people comment on that? Did parents comment on that comment on the top of the information that they were given?
Nobody has ever complained about it. I think it has made them more. I think it has made people more aware. I think it's important, and I think, as you know, from being involved in the National Review of Asthma Deaths, which is really what has triggered off a lot of the work that we've done in Northern Ireland, that this is something that you can't take lightly, and a lot of parents do not know that asthma can kill. And a lot of young people and teenagers are not aware that asthma can kill. So they are oblivious to that. And then once that is flagged up to them, they realize that then, yes, this is something that we do need to really kind of focus on. And a lot of the treatments are so easily accessible and so easy to take that it's an easy preventative of the danger.
That's very interesting, because, I mean, to be honest, that's always been my approach as well, is to explain very clearly to parents and people who don't take medication regularly or who don't attend for reviews. I would always lay it on the line and say what the risks are really. But as we're all aware, asthma deaths are really not that common. The tragedy is that most of them are preventable. And so we come on to the next section. This is really something that's really important for both parents and also for healthcare providers and doctors who think that it might not be worth investing money or funding or time in doing the kind of work that you've done. So can you talk about the results of this work in terms of what's happened for people with asthma, but also in terms of workload for the healthcare professionals? How did this help?
Well, I'll give the results, and then you can, Leslie, talk about the workload. In what we did was Northern Ireland has a very good electronic care record. So all GP attendances out of hours is all recorded, and we can get that electronically. So we got permission as a service development to look at the 1 year before the children, the asthmatics that were in our study. How often did they go to their GP? How often did they need oral steroid rescue medicine? How often did they come to out of hours? How often did they come to ED? And how often did they need admitted? And by definition, these were children who had come to the ED or been admitted. So they and had been more than had two attendances in the previous 6 months. So we then looked at the end of the program, when they'd been to Leslie's clinic for maybe 8 weeks or so, and was discharged. We looked at the year following that, and how often did they need oral corticosteroid rescue, attend EDs out of hours, or be admitted. And there was dramatic reductions in that, very, very statistically significant reductions. And in fact, most people, I think 75+%, had none of these: no oral corticosteroids, no attendances at the ED department, no admissions, no out of hours, and which was what we were trying to achieve for that high-risk group. And the other thing that we did notice, because using the electronic care record, we are able to pick up how many refills do the people with asthma collect. So that's a good, well, it's not an excellent, but it's a general monitor of how often you're using your inhaler. So if you're not picking up refills, it usually means that you're not taking your inhaler every day, your preventer. And that would be something we would routinely look at in the clinic. So when somebody's referred to the clinic, we would look and see, are they actually getting refills? Are they taking their preventer? So we looked at that the year before and the year after. And the year before, the figures were appalling, in that about 45% of the children were taking about 50% of the doses, about half the doses they should. And only 4% of children were taking more than 80% of the dose, which, generally speaking, you need to take somewhere between 50 and 80% of a dose to be getting benefit. And then at the end, when we looked at 1 year later, the good news was 96% of people had taken their preventer more than 50% of the time, more than half the time, although only 41% were taking it more than 80%. But the bulk of the adherence had vastly improved, where most people were taking it more than half the doses, which I'm sure, and we also know they were then taking it correctly. So they were using correct inhaler technique and using it much more frequently than before. So we felt that was what was probably caused it, the beneficial effects.
Yeah. And so these children had fewer attacks, they had fewer courses of oral corticosteroids, and they were collecting their medication, which is a wonderful outcome. And the point being that, as you say, if they're taking preventer medication, and if they're using their inhaler correctly, there's a good chance they're not going to have another attack.
Yeah, correct.
This is what I was referring to in terms of workload for managers, because the benefits are really that there's reduced workload for healthcare professionals and also reduced cost for the health service and great benefit for the families. And so, Leslie, do you want to add anything to what Mike has said about that?
Well, I suppose, I mean, data shows that asthma attacks cost, and that's adults and children, cost more than £1 billion to the health service UK wide. So any reduction in those attendances acutely will be much appreciated. When we had all our data put together, obviously we presented it at various different events, and at one of the meetings, our public health authority spoke afterwards to us and asked if they could consider doing it as a regional initiative. So throughout Northern Ireland now, there should be an initiative where any child who's admitted acutely, and we have asthma nurses and specialist asthma nurses in all district general hospitals and the tertiary centre, who will follow up those children the same way as we started off doing it in Belfast. But I suppose again, it's having the data there to show, because a lot of things you may know in your head that is should work, but if you don't have the data to back that up, it's very hard to get funding to encourage that to go through and promote it to go through. And I suppose now our public health authority and our boards are asking, so how can we prevent them coming to casualty in the first place? So that's probably the next step. The next step forward would be looking at initiatives, and I do know there are some good initiatives out there whereby you can start to get into primary care and hopefully start to reduce it from that level, as opposed to letting them actually come to casualty or into the wards as acute admissions. And if we could prevent that, it would be just amazing. But I think the key out of everything is maintenance of treatment. And if children continue to take their treatment that they've been prescribed as their preventative treatment, it should, in most occasions, prevent any acute asthma attacks. And if parents know what to do when their child's unwell, then again, that is very integral in helping to prevent asthma attacks, asthma deaths, and acute admissions.
And so how widely has this been rolled out?
So it's the region, wouldn't you agree, Mike? It's a regional initiative.
Yeah,
it's Northern
the
Ireland.
Department of Health wanted it rolled out in all of Northern Ireland into any unit that looks after children, and they were also considering it for the adults service as well. The problem, the plan was just before COVID, this was going to be rolled out. Then COVID happened, and the staff were all removed. And in fact, during COVID, I don't think there were many asthma attacks because we were all distancing ourselves and isolating. And I think they're obviously 2 years later, I've retired, so I don't really know now. But I suspect there are going to be challenges to get it rolled out properly. And one of the things that most frustrates me is some of my pediatric colleagues say, well, if you only saw people once and just showed them their inhaler, at least they'll be getting that. And the nurses will be able to see far more patients. But I just go back to what the parents and children with asthma said. They wanted it done properly so that this group of people would have mastered all the skills. And as you know, Mark, if you just show somebody how to use their inhaler that night, about 10 to 30% can do it, and the remainder can't.
Yeah. And I suppose the difficulty that I have really, and I did an interview with Richard Beasley on Monday or a few days ago, and what he's saying really is that we've got the evidence, and now you guys have clearly demonstrated a system that works. So we've got evidence that it works. And why on earth, if we believe in evidence-based medicine, why on earth isn't something like this rolled out very widely? And that's one of the reasons why I wanted to talk to you both, because I can't see any obvious reason why this shouldn't be rolled out in the whole country, really. We've got so many children, as you said, Leslie, having asthma attacks. And, one attack is too many for a child, really, and we need to try and prevent future attacks. So this is really a fascinating program, and I'm hoping that it will be rolled out and that both health authorities throughout the whole of the UK will do something about that. So, is there anything extra that either of you would like to add about children's asthma management that you'd like to see happening in the UK?
One thing I think is important, patients and parents coming to me when I was a pediatrician and pushing me, why can we not do this? Can we not do that? I would really stress, if you've got asthma, I would want to make sure, firstly, you see a specialist, and it could be in primary care, particularly an asthma nurse, and that she has time to talk to you, that she can go over and make sure you have mastered your inhaler and that you have mastered the written management plan, which is it's really supported self-care, that you have mastered them, you know how to do it, you know how to take your inhaler correctly, you know what to take and when. And I think that just is not happening. But if patients demand it, if people with asthma are demanding it, it eventually will happen.
Yes, I would agree with that as well. Don't just assume if you're at an appointment that when you see it being done that you can do it when you leave, because quite often it's like anything you may not be able to do it, especially if if your child's inhaler has changed. And I think that's where face-to-face reviews are very good, because at least then the practice nurse or whoever's doing an annual review can then watch as your child demonstrates this back to them and make sure that they're actually using the right device, that they're using it correctly, and then that you know when they should be using it, how often they should be using it in a day, when it's empty, and that you can follow that written personalized asthma action plan. There are videos that have been done by Asthma Lung UK that you can access online, and there are so many different websites now where you can go to just to look things up and to get a wee bit more information. That is so important. So if you don't understand, speak to somebody who can help you. And then again, if you were using a lot of your reliever, that's the time, or if your child's using an awful lot of the reliever in the week, that they need to go and maybe get assessed by the practice nurse, or you need to speak to somebody, because we have tried to reduce the use of reliever medication to as and when required. But if you're needing to use a lot of relief, if you're using it more than 3 times acutely in a week for symptoms, then it's maybe time to get somebody to go through your treatment plan with you again and to just do another bit of an assessment. And the other thing I would advise parents is never worry about getting help if you're worried about your child's breathing, because if you access that help early, as I always say to my parents, I would rather you came to the ED department if you're worried about your child and their salbutamol is not working, and that they see you and send you home within a few hours, than that your child comes in really unwell. So it's about getting that help quickly and not waiting until it's too late. So I think that's probably what my advice would be to parents, and to ensure that they always have their inhalers, that they order them in good time so that they're not running out.
There's some really nice, clear messages. And what about any messages for decision makers? So for the healthcare managers, have you got any messages for them?
No, well, we've been trying to get them to implement and make sure they're rolling out our care pathway. And also we've been we initially tried, and the GPs were meant to be involved, but there is one practice that has some excellent data where they got everybody in 1 year that had an acute episode, got oral steroids, went to ED, and or needed nebulized in their practice. They put them all onto a program, and the following year they had nobody went to hospital. That's one practice. Yeah. So just taking the acute attacks and using that as the point of entry and making sure everybody was properly educated, they then reduced acute attacks in that one practice.
It would be good to get back to face-to-face annual reviews instead of online or telephone annual reviews. I don't really see how you can assess somebody's inhaler technique through an email. And it's a tick box saying, do you know how to use your inhaler? Of course, the patient's going to tick yes. So I think that's another thing that we need to get back to as well, as face-to-face reviews for these patients, these children and families where their children have asthma.
I mean, my take from what you guys have shown is it comes back to something that I've been shouting about for quite a long time, that I don't think an annual review is really appropriate in asthma, because this is a disease that can flare up from minute to minute, and seeing somebody once a year on their birthday or before the payment comes in at the end of the year for general practitioners in the UK, in my view, is not very helpful. And you've shown so clearly that a review after an asthma attack is so valuable. And excuse me, I don't understand why the authorities, like the Quality Outcomes Framework, don't really mandate a post-attack review rather than an annual review, because that's the time that you're going to make a big difference.
I think I would agree with you there as well. But and I know there is good work as well going on in the UK in some areas, whereby the hospital-based nurse specialist will go out and sit with the practice nurse, and that's all done through funding which has been agreed with the GPs, and those practice nurses are guaranteed to have half an hour for appointments therewith after that. So they've been shown to reduce acute admissions to hospital as well. But I sometimes get frustrated myself, because I think asthma is just seen as it's only just asthma in inverted commas, whereas we do know that asthma can kill. It can be a very serious disease.
Yeah, and I think that's a good place for us to end this discussion, which has been fascinating. So thank you both very much for joining us today. And I'm hoping that you'll get some feedback. If I get any feedback, I'll pass it on to you. You'll probably get requests for more details about your program, if I'm not mistaken. So thank you both very much.